about bed in thoracic malignancies. تفضل دكتور أحمد.
Thank you so much for inviting me. Okay. Sorry. So goals and objectives of this lecture is to acquaint the radiologist to imaging strategies used to assess lung nodules, discuss the various histopathologic types of lung cancer and their common imaging features, provide an overview of the updated 9th edition of the TNM classification of lung cancers, describe the role of PET-CT in management of different lung cancers, and briefly discuss different cancers including mesothelioma, pleural mets, and thymic tumors, and as well as the role of PET-CT. This is the agenda for today. So lung cancer is the second most common malignancy worldwide. Risk factors, as we all know, include smoking, asbestos exposure, and radiation. Lung cancers can be discovered accidentally for an imaging workup done for other reasons. Patient may present with either localized disease or metastatic disease, depending on the stage of presentation. Symptoms may include local invasion or compression of the nearby structures. Metastatic lung cancers can manifest with neurologic deficits due to brain metastasis, spinal cord compression, or jaundice or bone pain. Small lung cancer, which is one of the types of lung cancer, can initially present with paraneoplastic syndrome. Evaluation of lung nodule. So by definition, lung nodule is a single lesion, which is by definition less than 3 centimeters, surrounded by normal lung parenchyma and no associated distal collapse or lymphadenopathy. Although the most common etiology for single solitary pulmonary nodule is likely related to benign lesions, it can be the first manifestation of lung cancer. So FDG PET-CT has been shown to be useful in evaluating lung nodules, and it's very important to understand this concept that it is beneficial in nodules more than 0.8 centimeter, meaning that anything less than 0.8 centimeter PET-CT can be limited in evaluating of these lesions. So PET-CT is advised in patients who are at low or moderate risk of malignancy. It can also be beneficial in high-risk patient for a local extent of disease if it turns to be cancer, as well as staging. FDG PET-CT parameters include any SUV max above 2.5, metabolic activity greater than the mediastinal blood pool, or if the nodule is less than 1 or 0.8 centimeter, any activity is considered to be concerning. Nodules can be occult on PET-CT, specifically in adenocarcinomas, so I wouldn't rely only on the degree of uptake. If the nodule is associated with suspicious features on CT, such as spiculated margin, I would still biopsy this nodule. Flushner guidelines, as you can see, they do stratify nodules based on the risk, based on the number. I want to emphasize on size of the nodule has to be more than 8 millimeter and has to be solid in attenuation. If that's the case, PET-CT can be useful in those cases. Anything that is not solid or less than 8 millimeter, PET-CT will be very limited. Classification of primary lung cancer. So non-small lung cancers represent 85% of all lung cancers. Adenocarcinoma has now replaced squamous cell carcinoma and is considered to be the most common type of lung cancer. Almost representing 50% of lung cancers can be solid, ground glass, or speculated. If it's solid or ground glass, usually PET-CT will be limited in evaluating those cases. Squamous cell carcinoma has a strong association with smoking, as we all know, and is usually intensely avid on PET-CT and is associated with cavitation or SVC syndrome obstruction. Bronchial carcinoid are usually central and associated with endobronchial component, and it can result in post-obstructive atelectasis. Depending on the tumor differentiation, it could be imaged by FDG or dotatate. Well-differentiated tumors are better imaged by dotatate. Poorly differentiated tumors are better imaged by FDG. Large cell represent like roughly 10% of the cancers, and it's usually peripheral in location. Small lung cancers, although it's considered to be less common, it is a very aggressive tumor. 70% of the patient presents with distant metastatic disease at the time of presentation. They have high association with paraneoplastic syndrome, and PET-CT can be limited in these cases, as we explain later. So this is a case of a primary lung adenocarcinoma. As you can see, it does have uptake, very minimal uptake compared to the mediastinal blood pool. So just be aware that adenocarcinomas can be occult on PET-CT. This is a squamous cell carcinoma presented with avid uptake and pleural metastasis. This is a small lung cancer, which can be broadly classified into limited disease or extensive disease, as we'll talk later in the TNM staging. So ninth edition of the TNM staging, it's very important to understand the TNM concepts. So TT tumors are tumors that are larger than 3 centimeter, but less than or equal to 5 centimeter, and may involve the main bronchus and can be associated with post-obstructive atelectasis. T3 tumors are by definition more than 5 centimeter, but less than 7 centimeter. They may involve the pleura, chest wall. They may lead to phrenic nerve paralysis. T4 staging is any tumor above 7 centimeter, which has invaded into the carina, diaphragm, as well as nodules in the ipsilateral lung. End staging, N2 versus N3. N2 is any lymph node that is in the ipsilateral mediastinal nodal stations. Any contralateral nodal station is by definition N3, and this is very important, as we will see later, because this is considered to be irresectable disease if patient has N3 disease. M1A is metastasis to a contralateral lung. M1B is metastasis to a single extra thoracic site. M1C is multiple metastasis. So how do we manage lung cancers? So accurate initial staging of lung cancers is very important to select the appropriate therapy, as well as predict prognosis of these cancers. Management of non-small lung cancer depend on the T and M combination. So early stages, including stage 1, 2, can be managed by surgical resection, including lobectomy, sublobar resection, or even pneumonectomy. As we said, stage 3B is when patient has an N3 nodal metastasis, which is considered by definition irresectable. So patient is not considered surgical candidate for this time. Stage 4 is associated with very poor prognosis, and prognosis drops significantly below 10%. Small lung cancer, as we explained, is an extremely aggressive tumor. It originates from the neuroendocrine tumor, so some institutions may end up imaging small lung cancers with dotatate. It is associated with rapid growth and usually metastasizes at the time of presentation. So role of PET-CT in this case is not really defined, because most patients will have metastasis. So what benefit is PET-CT adding? But still, some institutes will still do the PET-CT for small lung cancer, as we'll show later. Small lung cancer can be staged using the TNM staging. They can also be staged using the broad staging, including the limited disease versus extensive disease. It's very important to understand that even if the patient have a contralateral mediastinal adenopathy, by definition, they are still considered to be limited disease in the small cell lung cancer. Standard therapy for patients with limited disease small cell lung cancer include chemotherapy, and they may actually have radiotherapy due to high potential of developing brain mets in those patients. In extensive disease, the mainstay is systemic chemotherapy. They may get radiation as part of palliation. So what is the role of PET-CT in lung cancers? So National Comprehensive Cancer Center recommends the use, as we said, FDG in all non-small lung cancer. The role of PET-CT is not well defined in small lung cancer, but it could still be beneficial. So for T staging, it has been shown that the degree of metabolic activity does correlate with tumor aggressiveness in lung cancer, which could affect management and prognosis. Accurate tumor extension is also crucial if radiation is planned. It can also distinguish between post-obstructive atelectasis and primary tumor, as we'll show. It can also guide biopsy, so it can avoid any central necrotic portion of the tumor. As regard to end staging, as we said, have a very paramount significance in patients without any metastatic disease. N2 disease is still considered to be surgically resectable compared to N3 stage disease. Patients who undergo mediastinoscopy will usually have blind spots within the aortopulmonary and anterior mediastinal, as well as the posterior subcarinal nodal stations. So surgeons will rely heavily on PET-CT findings for evaluation of these lymph nodes. PET-CT can also detect nodal metastasis in any lymph node less than 1 centimeter. As regard to M staging, definitely PET-CT helps with PET staging, except in brain metastasis and adrenal lesions, as we explained before. Brain lesions can be occult on PET-CT because of the high intrinsic background of the brain. Also, adrenal lesions, evaluation of adrenal lesions can be limited on PET-CT because other benign conditions such as adenomas can light up on FDG PET-CT. So if it's a new adrenal nodule that developed during the course of treatment, we can suggest that it's a metastatic disease, but on a baseline, if we're faced with a hypermetabolic nodule in the adrenal gland, we would recommend obtaining a CT or MRI adrenal protocol. As regard the role of PET-CT in post-therapy, FDG PET-CT is not routinely ordered in cases of lung cancer, except if there's concern that the patient is not responding to treatment or there is concern for recurrent disease. If an interim PET-CT is ordered in these cases, it's usually obtained 6 months after the treatment. FDG PET-CT has the advantage over CT that it can identify recurrent disease. It can also navigate any challenges and discordance between CT and histologic biopsy resulting from post-radiation inflammation. PET-CT can also detect tumor progression in 30% of the cases, and it can identify early patients who are not responding to the chemotherapy. Confirmation of nodal status after induction chemotherapy is very important. The goal is to turn the patient from N3 to N2, meaning they are considered to be surgically resectable. PET-CT can help assess nodal involvement after chemotherapy. Hopkins criteria can be used in evaluation of lung cancer. With score 1, 2 to 3 is considered to be like a complete response. Score 4 and 5 is considered to be concerning for residual or new sites of disease. So those are different cases. So this is a patient who had squamous cell carcinoma, and as you can see here on CT, we're faced with this large opacity on CT. It's kind of hard to really delineate the margins of the tumor. So patient had a PET-CT, and as you can see, the tumor is metabolically heterogeneous. There are central areas of necrosis, but distally, this is all like central areas of distal collapse and pleural effusion. So in this case, patient had a T2 tumor rather than T3. This is another patient who has a large cell carcinoma. He had a CT as well as PET-CT. Patient was accurately staged as T3 and N2 because he had a single ipsilateral mediastinal lymph node. This is a different patient who had a squamous cell carcinoma, which is by definition a pancreas tumor if it involves the apical segment. In this case, actually had a central necrosis within the tumor. So it's very important if you're planning for biopsy to avoid the central part of the tumor. This is another patient who had a squamous cell carcinoma and had also lymphangitis, suspected lymphangitis carcinomatosis. He did have a phrenic nerve palsy. As you can see, there's elevation of the right copula of the diaphragm. This is another patient who had a squamous cell carcinoma. He was staged as T4 due to the involvement of the recurrent laryngeal nerve. As you can see here, there is increased activity related to the contralateral vocal cord due to compensatory hypertrophy. So the left vocal cord is paralyzed and does show like the sail sign, and there's compensatory increased activity on the right side, trying to compensate for the paralyzed recurrent laryngeal nerve. PET-CT can also be useful in patients who present with paraneoplastic syndrome. So this patient had an altered mental status, and they were concerned about malignancy. So he had an MRI as well as PET-CT, and as you can see, the patient had limbic encephalitis. We can see that there's increased activity correlating to the medial temporal lobes. And patient underwent PET-CT, and they had lung cancer. This is another patient who had small lung cancer, squamous lung cancer. They had a tumor, and they had bilateral lower extremity pain. So their symptoms initially presented was bilateral lower extremity pain. As you can see, this is the bone scan. You can see there's increased activity related to the anterior tibia bilaterally. PET-CT does also correlate to increased areas of uptake on the PET-CT, and you can see periosteal reaction on the CT portion. So this patient had a paraneoplastic syndrome. This is another patient who had a squamous cell carcinoma. He had a T2 disease as well as N3, so he had distant nodal metastasis. This is another patient who had a squamous cell carcinoma. So he had a T4 because he had a lymphangitis carcinomatosis within the ipsilateral lung. He had also M1C disease, meaning metastatic disease related to different organs, including the lung. As you can see, contralateral lung. He had an uptake in the left lower lung as well as bony metastasis. This is the different patient who was diagnosed with large cell carcinoma. He was staged as T3 N1 M1C. He had adrenal metastasis as well as muscle metastasis. If this patient was only imaged using CT, I think this nodule within the muscle will be really hard to be visualized just on CT. So PET-CT definitely helped with evaluation of metastatic disease burden. This is a different patient who has extensive disease. So extensive disease, small lung cancer. Even though the patient does have supraclavicular lymph nodes, by definition, they are still considered to be limited disease. This patient actually had a metastatic disease within the liver and the lung. But if we only had a supraclavicular lymph nodes, by definition, this patient would still be limited disease. This is another patient who was diagnosed with a squamous cell carcinoma. He had a contralateral nodal adenopathy, as well as different sites for osseous metastasis, staged as T4, N3, M1C. So as we discussed, PET-CT is limited in evaluating brain metastasis. So this patient had small lung cancer, and it's part of the staging for small lung cancer to do MRI of the brain because it does have a high propensity to go to the brain. So patient had an MRI, and they saw this enhancing lesion within the temporal lobe. He had also a PET-CT on the same day, and as you can see, there's no correlate on PET-CT. So PET-CT can be tricky in evaluating brain metastasis. This patient also had an adrenal nodule. If this is the baseline, I would not be able to decisively say it's an adrenal metastasis. But if this developed over the course of the therapy, I can suggest that it's an adrenal metastasis. This ended to be an adrenal metastasis. PET-CT can also be helpful for navigating post-treatment inflammatory changes. So this patient had radiation to their lung cancer. He had a non-small lung cancer. You can see there is diffusely increased uptake related to peribronchovascular interstitial thickening within the left upper and left lower lung lobe. And he repeated the PET-CT over the course of 1 year, and as you can see, the extent of uptake as well as soft tissue correlate is decreasing. So this is consistent with radiation pneumonitis. Also, PET-CT can be useful in cases where there's concern for recurrent disease. This patient had a non-small lung cancer who was treated with surgical resection, and there was concern for recurrent disease. He underwent a PET-CT, and as you can see, that there is new hypermetabolic masses within the surgical bed, as well as ipsilateral and mediastinal lymph nodes and metastatic sites of disease. So PET-CT can be helpful in those cases. Malignant pleural mesothelioma is an aggressive tumor associated with a prior history, as we all know, of asbestos exposure. It does arise from the serosal surface of the pleura. It can also arise from extrapleural membranes, including the peritoneum and the pericardium. FDG PET-CT is more superior than CT for evaluating disease burden because mesotheliomas are usually avid on PET-CT. However, PET-CT is only ordered if the patient is considered to be surgically resectable. The NCCN endorses the use, as we said, of the FDG for patients who are considered to be surgically resectable. PET-CT can understage nodal involvement in mesothelioma because pleural involvement of the mediastinum can hide underlying nodal adenopathy. So PET-CT is not considered a good modality for end staging in mesotheliomas. If patient is planned to have a talc pleurodesis as part of their therapy to obliterate their pleura, usually PET-CT is obtained before that to accurately stage those diseases. Because as Dr. Morton was talking, talc pleurodesis is associated with strong inflammatory response after application. So those are different cases. This is an image. This is a MIP image of PET-CT, and you can see there is diffuse increased activity localizing to the entire hemothorax. This is another patient who had extensive disease related to the pleura on the left side. My first differential in this case would be mesothelioma. The second differential would be diffuse breast metastasis, pleural breast metastasis in a female. Metastatic pleural involvement is the most common pleural malignancy. The predominant underlying primary disease are bronchogenic carcinomas, breast carcinomas, and lymphoma. The most frequent manifestations of metastatic pleural involvement is pleural effusion. PET-CT has been shown to identify malignant pleural effusion in 88 to 100% of the patients. On PET-CT, malignant pleural effusions are often hypermetabolic. They can be associated with hypermetabolic pleural nodules or masses. So this is a patient who had a breast cancer, and as we can see on the PET-CT, the patient had pleural effusion, and there are subtle hypermetabolic nodules related to the pleura. This is a patient also had a breast cancer, and he had a very minimal hypermetabolic pleural effusion, which was concerning for malignant effusion, recurrent malignant pleural effusion, and they did aspiration, and it turned to be pleural metastasis. Shifting gears to thymic tumors, which will be my last topic. Primary thymic tumors consists of a wide range of disorders, including thymomas, thymic rebound hyperplasias, thymic carcinomas, and thymic neuroendocrine tumors. The peak age for these tumors is 70 to 74. They all arise from the epithelial cells of the tumor. The thymic tumor, as we said, is a wide range of disease. Thymic rebound hyperplasias are considered to be a normal variant in young patients who received chemotherapy, or even in young adolescents or kids. While thymic carcinomas are considered to be the most aggressive part of the spectrum. So thymic rebound hyperplasia can be hypermetabolic on PET-CT. The clue is it's usually lobulated, triangular in shape, and usually there is history related to recent chemotherapy, or it can be even normal physiologic finding in young adolescents. Thymomas and thymic carcinomas can present with local or metastatic symptoms. Symptoms can be due to can be seen as hoarseness of voice due to recurrent laryngeal nerve palsy, compression of the SVC. Thymomas account for 25% of all mediastinal tumors and 50% of all anterior mediastinal lesions. Myasthenia gravis can happen in up to 50% of thymoma patients, and only 10 to 15% of patients with myasthenia gravis will have thymoma. There's no uniform consensus whether PET-CT can accurately distinguish between thymomas and thymic carcinomas, but in general, it has been suggested that thymomas tend to be lower in metabolic uptake as well as soft tissue invasion compared to thymic carcinomas, which is often associated with aggressive behavior invading the chest wall and increased uptake. Thymic neuroendocrine tumors, as well as small lung cancers, as we talked, as well as bronchial carcinoids, can be imaged by dotatate. So if you know if the patient has a biopsy-proven, well-differentiated tumor, dotatate can be used for imaging of these disorders. So those are different patients with thymomas. As you can see, the uptake is not really that hot, but it's often more aggressive compared to the thymic rebound hyperplasia. So there's more soft tissue component related to that, and there's more increased activities. Thymic carcinomas on the other side are associated with more aggressive course, so they tend to invade the chest wall, they tend to have more increased uptake, and they can metastasize to the pleura. Thank you so much.
Any question for Dr. Ahmed, please?
Dr. Ahmed, you have noted that adenocarcinoma has been the most common malignant tumor. Yes, here.
Sorry.